Bismillahirrahmanirrahim. Thank you very much, Dr. Shahjar, and for kind introduction. My topic is not all the novel therapies we can discuss in a very short time, that only we can discuss a couple of new things probably for you, for me as well. And I'm very grateful to Dr. Yusuf Kamal. He has come all the way from Karachi and the other, so we welcome him in Lahore. So what we have, that basically everybody knows that Pakistan belongs to that area where the diabetes is highly prevalent disease. It's not disease, it's a condition, and I think hardly, and we know something which is very surprising for me, that why with this part of the world particularly have the highest prevalence rate. Not the Bangladesh, not the India, some other factors might be where some of you can throw some light among the panelists why we are having such a high prevalent rate of this condition. And Pakistan is ranked third. Everybody knows that around more than 30% population is diabetic, and some of the big chunk of the people, they are having diabetes, but they don't know they are having diabetes. So the diabetes is not only because the cost of the treatment of diabetes is not much. It is the treatment of the complication which is quite expensive. And you can well imagine, you can see the long list of complications, macrovascular and microvascular complication, which are generated because of the not treating properly, or not treating early, not treating intensively at the initial stage. The lesson which we have learned from the UK PDS trial, if you treat the diabetes at a very early stage intensively, so you can have the complication, a legacy effect even after the 20 years down the road. So coronary artery disease is one of the cause of death among the diabetics, and around female are more affected. And heart failure is again a thing which is need to be considered. So peripheral artery disease, stroke, retinopathy, and nephropathy. The topic which we are discussing today, the one of the microvascular complication, which is very, very common in this, most of in the patient, which we see in our clinics. Majority of them, they are coming with the complaint of some neuropathic complaints. But the problem is when the person is having the cardiac autonomic neuropathy, so this is a very dangerous thing, and the prevalence is around 31 to 73% patients with type 2 diabetes. So fortunately enough, so we have the Pakistani, what is the pain actually? Pain actually is the unpleasant sensory and emotional experience. So when you have the pain, because of the sensation and sensory involvement, and you have the emotional experience along with it. So it is associated because of that. Actually, there is a potential tissue damage, or actually actual damage is there. So as a result of this damage, you can have the bad sensation and the bad emotional effect or bad emotional experience. So you can see the 50% of the patient with diabetes, they are having diabetic neuropathy. And among 50% of around 20 to 40, 24% of the patient, they are having the diabetes, but they have the painful condition along associated with it. So this is the Pakistani data that we have with the Metabesity Clinic, and we have the study published with the mirror outcome. So these were we are having a three risk factors: hypertension, dyslipidemia, and obesity. And the diabetic peripheral neuropathy was around 40% in this part of the world. This is the Pakistani data which we are presenting. But neuropathic pain, it negatively affects the quality of life. What is the quality of life? We ask our patient that please do some exercise to improve your glycemic control, but they are unable to walk properly because of they don't exercise. Their ability to exercise is decreased. Their ability to walk is decreased. So walking has shown improve the hemoglobin A1C, but they're not able to walk properly. So second thing is that the pain which they are having, it interferes with the sleep. They don't sleep for at least 6 hours, which is recommended. Sleep hygiene is not being observed. So sleep depth is there. So if you don't sleep, if you sleep today for 2 hours and the next day again sleep for 2 hours, so the sleep depth of 4 hours. So that cumulatively would be 8 hours depth. So this is thing which is affect their mind and their body negatively. So that affect their metabolic and endocrine control as well. Because if they're not sleeping properly, sleep hygiene is not being observed, so their sugar level is not under control. So pain is the last but not the least. Pain is associated with depression. So someone is experiencing pain chronically, so depression is definitely there. The other thing is that we think it is normally said that if you are having a good glycemic control, that obviously you will have the less incidence of peripheral neuropathy, and you have the less, it is the predictor of the presence of the pain. So a study was conducted. The 17% people, they were having the A1C less than 7%, they still were having the complaint of the pain. And I think there is a deficiency on the part of the healthcare professional. 83% of the patients, they tell their doctor they are having pain. But 50%, but the doctor, they fail to understand. There is communication gap between the patient and the doctor. They fail to understand what the patient is telling you. The patient is complaining of peripheral neuropathy and peripheral neuropathic pain. Only the healthcare professionals, they consider that 40% of their patient, they are having the pain. So there is a gap, communication gap between the doctors and the patient. So that is probably lead to the treatment inertia, that they don't intensify the treatment of this pain. So the effect and duration of diabetes or diabetic neuropathy. So you can see on this right panel. So even in type 2 diabetic patient, at the very initial stage, like around 1 year, 2 years, or at the time of the presentation of the diabetes, the patient can have the symptomatology. And it is very much related with the age of the patient. As the age advances, the complication of the neuropathy, like neuropathy, they also progressing. So there should be stepwise approach for screening and diagnosing the peripheral neuropathy. So we have certain approaches. First of all, the non-pharmacological approach, which is very common. So we have to change the lifestyle. If you do exercise, there's improvement in the symptomatology. And if you exercise regularly, again, you have the decreased symptomatology. And if it is not effective, so you have to do something invasive, slight invasive, like nerve stimulation, high frequency spinal cord stimulation, thing like this, which is available over here. The topical treatment is again popular. So there's the combination therapy, like multiple drug combinations, some pharmaceutical, nutraceutical, they are in the market, they are used for the treatment of neuropathy. But the pharmacological treatment approved by the American Neurology Society and FDA, so they approved some anticonvulsants like pregabalin on the top, gabapentin and duloxetine and tricyclic antidepressant. So remember one thing, they are not treating the underlying causative problem, because they are not treating the underlying pathophysiology. We are treating the not the pathophysiology, but we are just we are providing the comfort to the patient by provision of these medication. So we are treating the patient symptomatically. We try to treat the pain. We don't treat the pathophysiology with these agents, definitely, to remember one point. So the FDA approves pregabalin, duloxetine, and the new agent, which is not approved by the FDA, is mirogabalin. So this is the gabapentinoids. The pregabalin is a very popular medication nowadays. You know, this is used for the painful diabetic neuropathy and post-herpetic neuralgia, and in the seizures and fibromyalgia, and any pain which is associated with the nerve tissue injury. So it is used. The pregabalin is there. Gabapentin, they were used judiciously in the past, so they are good for the post-herpetic neuralgia and partial onset seizures. Mirogabalin, because it is not approved by the FDA, and duloxetine is, so it is approved for the generalized anxiety disorders and painful diabetic neuropathy and fibromyalgia, and amitriptyline, because they have certain side effects, but they're good agents. Initially, people have been treating with them the peripheral neuropathy, painful neuropathy with them. So topical agents are becoming popular. So this is the new thing, this pregabalin ER. This is extended release formulation. So how it is different from the immediate release, which we have the two kind of products or compounds. One is pregabalin IR, immediate release, which is present currently in the market, pregabalin IR. And second is pregabalin ER, extended release, because this it binds to alpha to delta receptor site, a subunit of voltage gated calcium channel in the central nervous system. So the good thing is that it's once a day or daily you can take after evening meal, and because this product stays in the stomach for a pretty long time, and this IR formulation, it slowly releases the pregabalin, and absorption is in small intestine and proximal colon. So what is the benefit of the patient? The patient sleeps well during the night, so he is free from the pain. So these are the indication neuropathic pain associated with peripheral neuropathy and post-herpetic neuralgia. So how this control release allows more consistent blood level of medication compared to the immediate release, which has fluctuation in the blood levels. So you have to give the patient once a day, twice a day, 3 times a day, these immediate release preparation or instant release preparation. So the compliance is very bad if you are taking 3 tablets a day compared to if you are taking the 1 tablet a day. So similarly, it has the reduced side effect like dizziness and peripheral edema, which is very commonly seen when you are particularly using with the calcium channel blockers. So if you come across that the patient presents to do with the peripheral edema. So by maintaining a stable plasma level, it may lead to fewer side effects compared to the immediate release compound. So improved dosing convenience, because you have to give this medication once a day, especially at night, and better symptoms management compared to the immediate release. So this is the score. Efficacy and safety is basically it has been compared with the control group. You have improvement in the DPRS score, so you have improvement in the pain effectively, and safety is there, and anxiety and depression are improved with the pain control. And it is basically the non-inferiority study, that because it is not inferior to the immediate release or this extended release, they are comparable. So it has slightly, this extended release is slightly better if you see the black column of this study. So you have, but this is the non-inferiority phase 3 trial. So this is the dosage conversion. So if you want to use the 75 milligram, so you have to give the 82.5 milligram dosage to this patient. So if you are planning to 150 milligram, the tablet is available 165. But remember, if you give the 150 milligram, so if you give the 165, so this is the extended release preparation. But if you want to give 247 milligrams, so 3 tablets of 82.5 milligram can be given at once. And if you want to prescribe 495 milligrams, so you have to give the 3 tablets of 165 milligram. So accordingly, if you are planning to give the very high dose like 660 milligram, so you have to give the 330 milligram 2 tablets taken once a day, especially at night after the meal. So the key feature of why we are preferring it, because it's a once daily dose, easy to switch pregabalin, so you can easily switch your patient from the IR preparation to the ER preparation, and cost effective because you have to take 1 tablet, so your cost is less, and it is better efficacy and safety profile. You have the less chances of complications on the side effects with it. The other product, this new product is mirogabalin. This is not FDA approved. This is a new agent in the market. So this is again very effective medication. Probably the FDA is going to approve sooner or later, obviously. So they need more trial for the regulatory affairs. So the indication of mirogabalin is peripheral neuropathy, as we are interested. So low back pain, fibromyalgia, post-herpetic neuralgia, and sciatica. So these are the indication of mirogabalin. So what is miro basically? It's a novel gabapentinoid that targets selectively effective treatment of the neuropathic pain. So it selects alpha 2 delta subunit voltage gated channel that has shown better efficacy, other therapies, and better tolerability. It has two effects. One effect is mechanism of action, that mirogabalin has high affinity for the alpha 2 delta 1 subunit receptors at the dorsal root ganglion. But where you are having side effect, it is the cerebellum where you are having a side effect. So it has fast dissociation. So it has strong association at the receptor side and fast dissociation at the cerebellar level. So that's have you at the low side effect profile with it. So adverse effect, when you compare it with pregabalin, obviously the sooner or later the FDA is going to approve this medication. So have the left dizziness, less monolens. So you have like 7.3 compared to 12.2%, 4.9 versus 14.6% with the pregabalin. So dosages, you start with 5 milligram given twice a day. The dose is increased by 5 milligram at an interval of at least 1 week to 15 milligram given orally twice daily. So your dose should be like not more than 15 milligram. So you hang around between 10 milligram to 15 milligram as far as the dosage of mirogabalin is concerned. So you can slowly up titrate. So because the availability of the mirogabalin is 2.5, 5 milligram and 10 milligram and 15 milligram. If you want to use the 15 milligram in a day, so you can make it 5 milligram and 2.5 milligram tablets. So it's a 7.5 milligram that makes it 15 milligram in a day. So the maintenance dose is between the 10 milligram to 15 milligram. So this is the product which is available. And thank you very much for your kind attention. I think that I have completed my presentation within time.